For those of you who don't know me, my name is James Andruko. I'm one of the emergency doctors and researchers here in Calgary. And today I'll be talking about our Calgary chest pain pathway, just as a bit of a preamble to what Andrew's going to be talking about, which is risk stratification of chest pain patients after rule out of MI. So we do have a pathway for that, and that's what we're going to be talking about today. Many of you may already be familiar with it, but we're going to talk about it in a bit more detail. So first thing, our disclosures. I have no personal financial relationships with industry, although I do have or did hold an unrestricted investigator-initiated research grant to study high sensitivity troponin. That was from Roche Diagnostics. They had no control of publication of the work or any say in how it was conducted. So the objectives of this talk are to review how to use our Calgary 2-hour high sensitivity troponin T chest pain pathway, and to present some local data validating its use. So first things, chest pain is one of the most common reasons for visiting an emergency department in Canada. There are about 600,000 annual visits in this country. However, most patients with chest pain or suspected ACS don't have myocardial infarction, and from the prior literature, we find that the AMI prevalence in most studies ranges between 8 and 15%. And we know that misdiagnoses can lead to serious morbidity, mortality, and medical legal risk. And so we do the best that we can to try and capture all the patients that do have ACS. Unfortunately, it also leads to a lot of downstream testing, which is something Andrew's going to get into in a bit more detail on how we can be a bit more streamlined in how we approach further risk stratification after MI rule out. And so we've had a high sensitivity troponin assay in the Calgary zone since 2012, but the use had been variable. So in May of 2019, we did implement a formal 2-hour high sensitivity pathway with buy-in from cardiology and other stakeholders. So why do we need a pathway? And so even despite a lot of literature out there showing the optimal ways to use high sensitivity troponin, and even despite our pathway right now being out for a year, there still is continued variation in both ordering and interpreting high sensitivity troponin results for patients with suspected cardiac ischemia, both among emergency staff and among consulting teams. And so the pathway, what it really does is provide a locally validated and evidence-based approach to risk stratifying patients with suspected ACS. It is supported by the cardiology leadership as well as by what was formerly called Calgary Laboratory Services, now Alberta Precision Labs. And ultimately, I think the biggest reason we should be using it is because it streamlines disposition and it improves patient care. So I think it's always useful to start with a case. This is a case of a patient I saw myself about 2 years ago now. And so this was a 79-year-old man of Southeast Asian ethnicity who had a bit of a language barrier, who came to the emergency department complaining of new exertional chest pain and leg weakness. He had a past medical history of CAD, MI, and a stent, hypertension, hyperlipidemia, and type 2 diabetes. His vital signs were normal. His ECG was normal sinus rhythm, heart rate of 72 with some non-specific changes, but that were really not any different from his baseline. His pain occurred about 2 hours ago while he was walking. He's now pain-free. His troponin results were a time zero troponin of 24 nanograms per liter, and at 2 hours, 32 nanograms per liter. And this patient was handed over to me by one of the other docs with a cardiology consult pending. So I continued my work, and I didn't go directly to reassess the patient at that time. I was seeing other patients. And about an hour later, the nurse pages me stating that cardiology has discharged the patient, and did I want to see him before he goes? So how do you think this patient should be managed based on that story? So should we just let the patient go because he's been seen and discharged by cardiology? Should we reassess the patient if he remains chest pain free, discharge him home? perform further testing, or consult a hospitalist for weakness not yet diagnosed. So we're going to be talking about the biomarkers today a lot, but still it comes down to performing a thorough assessment of a chest pain patient, or for any patient for that matter. History is everything. So just want to re-emphasize how important it is to get a quality history in making a realistic and comprehensive assessment of a patient. Because tests and biomarkers are really just one component of the overall assessment. For every patient, of course, we should be performing a focused physical exam and/or point of care cardiac ultrasound, primarily to exclude other diagnoses. When you've decided to rule out MI, we know that the evaluation is contingent on a couple of tests. So, of course, the electrocardiogram, and we know the importance of performing serial ECGs in patients that have active chest pain or high-risk presentations. And then, of course, the second foundational component of assessing chest pain patients is troponin. And so with conventional assays, we'd be performing serial troponins over 3 to 6 hours. But with our high sensitivity assay, we now have adopted a 2-hour pathway. And so when you typically are assessing patients using a conventional troponin assay, it's a binary interpretation. I'm not sure if you can see my mouse, but with day-to-day physiologic activity, there are normal physiologic variations that happen in troponin levels that are not pathologic. You may have a small ischemic event that causes a rise and fall in troponin. With conventional assays, they are not very sensitive and not very precise at their lower limits, so that it's very easy to miss a small ischemic event. And in the old days, if you had a chest pain story and your troponin was undetectable, and you thought that the patient did have a good story, you called it unstable angina and you consulted cardiology. And if you didn't, you called it non-cardiac chest pain and sent the patient home. And so that was where we really had a potential to miss patients with smaller ischemic events. Large ischemic events we reliably detect, and detectable levels of troponin on a conventional assay are generally pathologic and were thus considered a rule in. With high sensitivity assays, just as a recap, we're unblinded to a lot more data. So we are seeing most patients having their daily physiologic variations in troponin. There's a small number of patients that have undetectable levels, about in our research here, between 1/4 and 30% of patients. And but for most people, we can see what their troponin results are doing, and so we can detect small rises and falls. And rather than just simply interpreting troponins in a binary fashion as an absolute rule in or absolute rule out, we know that if they have very, very low levels of troponin, we can rule them out reliably. And for people with detectable levels, we measure serial levels over time to see if they're changing, to attempt to detect an acute myocardial injury. And if there's a significant amount of rise over time, or they cross an evidence-based threshold, then we consider them to have ruled in, and at which point we proceed with treating them. And so based on that understanding of high sensitivity troponin, there are guidelines out there that, like, this is from the 2015 European Society of Cardiology guidelines recommending how to optimally use these assays, which is a combination of low concentrations on arrival as well as serial changes over time. And this protocol can be used with any number of assays, as you can see. In Calgary, we developed our own pathway based on primarily the Reichlen 2-hour Roche high sensitivity T rule in, rule out algorithm, but also incorporating a rule out with patients with very low concentrations on arrival. And while this pathway might look a bit complex when you first look at it, We're going to break it down step by step just to make sure that you understand it. And it actually really makes it a whole lot more simple when you break it down in a stepwise approach. There are some people who will not meet any of the clear diagnostic criteria on the pathway, and so that they won't have very low or undetectable concentrations on arrival, nor will they meet a clear 2-hour rule out or a 2-hour rule in. Those people fall into the observational zone, and their disposition is a bit more nuanced, but we do provide guidance for that as well. And so there's a separate branch of the pathway which will help you assess patients in the observational zone. But let's break it down. So for any patient presenting with suspected ACS, of course, the first order of business is an exam and an ECG. If the patient is unstable or if they have an ischemic ECG, you treat them as ACS. If they're stable and they have a non-ischemic ECG, well, that's where troponin comes into play. And so you perform time zero troponin, and time zero being the first troponin when they arrive. So that's the 0-hour mark is when that first troponin is drawn. So with the first troponin, if the first troponin is less than 5 and the patient has had more than 3 hours since symptom onset, you can reliably rule them out for acute MI and identify them as being at low risk of 30-day MACE. On the other hand, if their initial troponin is 53 or greater, and that's been shown to be a reliable rule-in cutoff in the patient presenting with a clinical history compatible with suspected coronary ischemia. So if you don't meet either of those cutoffs, then the patient gets a 2-hour troponin. And at the 2-hour mark, we can look and see, do they meet a validated rule-out criterion? And so if their time zero and 2-hour troponin results are less than the 99th percentile, they're normal. And the change between those two values is less than 4, meaning a negligible change, they can be considered ruled out for MI with high sensitivity and also reasonably high sensitivity for 30-day MACE. On the other hand, if their 2-hour value crosses 53, or their change over that 2-hour period is significant, meaning 10 or more nanograms per liter change, then they also rule in and you proceed to treat them. All others go down the observational zone, which will be about 20. So about by the time you've used the time zero, the 2-hour rule in, rule out, you'll be able to effectively disposition about 75% of the patients. And so you're left with still about 25% that will fall into the observational zone. And again, as I said, the observational zone is a bit more nuanced. The bottom line being is if the patient's troponin levels are similar to their prior documented results, and they're not rising, and it's a low-risk presentation, then ACS is unlikely. Similarly, if you have no prior documented troponin results to compare with, you might want to send off a 4-hour troponin. If their 4-hour troponin remains below a rule-in cutoff, their delta, their change over time is low, and it's a low-risk presentation, ACS is unlikely. On the other hand, if their 4-hour crosses our rule-in threshold, either by absolute numbers or by the delta, they rule in. There's still going to be a population of patients in the 10% range where we'll still be unsure whether or not they have an ACS based on biomarkers, and then that's where your clinical judgment becomes very important. So does it work? I think that's the most important question. We've published several articles on this now. Most recently, this came out late last year, looking at undetectable troponin concentrations, that is less than 5 nanograms per liter, which is the limit of detection of our assay, and more than 3 hours of symptoms. And about 25% of patients would meet that cutoff. And we found that cutoff is 100% sensitive for both index and 30-day MI, and also highly sensitive for 30-day MACE. So again, about 98% sensitive for 30-day MACE, including revascularization, 30-day MI, or death. So it works. And that also means that we can rapidly disposition about 25% of the patients we see based on that initial troponin result alone. For all the people that have to go on to 2-hour troponin testing, if they meet the low risk criteria, their risk of an index MI is exceedingly low. In our own data set of 351 patients that met this criterion, which was 63% of our 2-hour population, it was 100% sensitive for index MI, a little bit less sensitive for 30-day MACE, but at 83.3%, but still connotes a low 30-day risk of MACE when you look at the negative predictive value of 96%. On the other hand, if you meet the rule-in criteria at 2 hours, the people always are concerned about the possibility of troponinitis and false positives with high sensitivity assays. However, this data set was adjudicated by myself and Tim Boyne, the president of Total Cardiology. And we agreed that, so we have good physician adjudicated outcomes, and that if you ruled in by this algorithm, your positive predictive value for index MI was about 83%. So more than 4 to 5 times, if you call someone positive by this pathway for an acute MI, 2 physicians would agree with you in an adjudicated diagnosis. With observational zone, there's still a number of patients that get left into this observational zone where they can't be clearly classified at 2 hours. It's just really careful. We have to be really careful with these patients because there still is a significant risk of index AMI of about 10%, and about 8.5% of these patients will still go on to 30-day revascularization. So the observational zone, I think people tend to be a bit cavalier about, saying, oh, well, it's not a clear rule-in. But I think we just, a word of caution that the bad outcomes do happen to these patients. So tips for navigating the observational zone: you can use the pathway as we've outlined already, but main thing is be cautious. If troponin levels aren't changing, and if they're near the patient's previously recorded baseline, ACS is unlikely. If they're different from the patient's prior baseline, or they're rising, even if it doesn't meet the ruled-in threshold, strongly consider ACS. And in that case, do a 4-hour troponin, repeat the ECG, reassess the patient, look for non-ischemic causes of myocardial injury, think about PE or myopericarditis or other things, and disposition cautiously. So back to our case. We had this 79-year-old man with a language barrier who complained of exertional chest pain and leg weakness. He had a non-specific ECG, a troponin that went from 24 to 32 at 2 hours, and is now pain-free and was discharged by cardiology. So this patient would fall into the observational zone based on our pathway. And according to our pathway, would be recommended for a reassessment and a 4-hour troponin. So I reassessed the patient. I found his story to be highly concerning for an ischemic cause. I spoke with the cardiology junior, kind of brushed it off, and she said she thought it was more of a problem with leg weakness. I expressed my concerns that he had a good story and he was in the observational zone, and I sent a 4-hour troponin and stated I wouldn't be discharging the patient home. His 4-hour troponin came back at 166, and he was admitted to cardiology for NSTEMI. Of note, his troponin peaked at 4,600 2 days later. Ultimately, he had multivessel CAD on cath that was unable to be intervened on with PCI, and so was managed medically. So take-home points from this talk are that, again, very low concentrations of troponin on arrival are highly sensitive for index AMI and are very, very sensitive for 30-day MACE. And so you can rapidly and safely rule out between 1/4 and 1/3 of our patients who present to the ED with chest pain based on this alone, provided that they don't, in your mind, have a very high-risk story. And so a little mnemonic to help you remember that can be arrive less than 5, stay alive. Take home point number 2 is that the combination of a non-ischemic ECG and a low risk set of 2-hour troponin results is 100% sensitive for AMI, so you're very, very unlikely to miss an acute MI, and is also quite sensitive, well, reasonably sensitive for 30-day MACE. Yeah, but again, yeah, you know, still 83% sensitivity. This is where history comes into play and assessing whether or not you think the patient does have a high-risk clinical history. But even if you played only the biomarkers alone, it's not bad. And with this pathway, you can safely rule out about 2/3 of the patients that we see. And so the mnemonic there is delta less than 4, out the door, provided that they don't have a high-risk clinical history. Take home point 3 is that for the 2-hour rule-in, the combination of either a troponin that crosses our rule-in threshold or a delta of greater than or equal to 10 is pretty accurate for acute MI. More than positive predictive value is more than 80%. So you're going to be correct more than 4 out of 5 times if you ruled someone in with these numbers alone. And about 30% of patients, of these patients, go on to 30-day revascularization. And so the mnemonic there is delta of 10 or more, cardiology floor. Last thing, what about patients that are transferred from other facilities? Well, we have similar high sensitivity pathways that are being used at surrounding centers. It's really important to know which assay is used in order to try to interpret those results. However, if someone is transferred with what are not clearly diagnostic troponin results from another center, you're not sure how to interpret them, start from the beginning with our pathway to be as evidence-based as possible. There's no way to convert between assays. They measure different molecules with different patterns of release and clearance. And there are links to each of these different pathways at the various sites on our on Insight under our physician resources clinical guidelines set. Anyone that wants to do a bit of extra reading, we have a journal article that summarizes how to use these in Canadian Journal of Cardiology from 2 years ago, and these are our references. If you have any other questions, feel free to reach out to me after. Andrew and I will be doing a joint Q&A session at the end of his talk. So you've ruled out MI. Now what? Andrew McCrae is going to tell you what.
All right. Thanks, James. And so, yeah, as James said, my name is Andrew McCrae. I'm an emergency physician and researcher, and I'm going to spend my time talking about what happens to patients with chest pain after they leave the emergency department. So, as James mentioned, chest pain is a really common high-risk emergency department presentation. Most of the patients that we see, we send home. If we were all together in person today, I'd probably ask for a show of hands, and it's harder to do on Zoom, but people can wave or give a thumbs up. If you've ever lost sleep thinking about a patient with chest pain that you've discharged from the emergency department. And I'm going to bet, because I can't see all of you while I'm screen sharing, that I'm not alone in this feeling. And so I'm going to talk about trying to get the right patient, the right follow-up at the right time after an emergency department evaluation for chest pain. I'm going to talk in order about why the decisions that we make around the time of discharge for patients with chest pain matter. I'm going to present some evidence that existing risk scores or risk stratification tools may not do what we think they do. And then I'm going to ask for your input on what direction you feel would be the most helpful for the next generation of chest pain research to try to help us get the right patients to the right follow-up at the right time. The first point I'm going to make is that follow-up decisions for the patients that we judge to be at low risk for an acute coronary syndrome really do matter. They matter in terms of patient outcomes. They matter in terms of health system sustainability. So it's in our interests and in our patients' interests to try to best match our disposition and referral decisions to the patient's degree of cardiovascular risk to ensure the patient's best chances of having a good outcome. The first piece of evidence I'm going to point to support this is a study that Andrew Howarth and some of our cardiology colleagues across Alberta presented at the AHA scientific sessions a couple of years ago. They looked at almost 30,000 patients in Alberta discharged from emergency departments after a chest pain encounter in the year 2012. And they compared outcomes between patients who were followed up in chest pain clinics, so cardiology clinics that have the capacity to do in-house non-invasive testing, versus other specialists, so internists or cardiologists outside of dedicated chest pain clinics, versus patients who either got no follow-up or follow-up with primary care providers. The first bit of good news is that the risk of adverse events after emergency discharge for chest pain in Alberta is really, really small. The 30-day mortality risk for these patients was 0.05%. And when you stretch that out to 3 months, the risk was still only 0.1%. So we're doing a really good job at making sure that the risk of the patients that we send home is really quite low. The risk of health system outcomes, so things like 30-day ED revisits and 30-day admissions, was also really small. But what they saw is that the risk of a health system event, like a 30-day ED revisit or admission, was substantially smaller among patients who were referred to chest pain clinics after an ED discharge compared to those who were followed by other specialists or who received primary care follow-up. So the conclusion here was that referral to a chest pain clinic was associated with potentially lower downstream health system utilization. There's substantially similar findings from Ontario, and I'm going to cite 2 studies to support this by the same group of authors. One study looked at almost 220,000 patients who were at relatively low risk, so they didn't have any diabetes or other substantial cardiovascular risk factors, who were discharged from the emergency department after a chest pain encounter. And what they observed is that among patients who had follow-up with a cardiologist compared to primary care follow-up or no follow-up at all, their adjusted hazard or the risk of 1-year death was substantially lower if they had cardiology follow-up. And the same thing was true among patients with higher risk profiles. So patients who were over 50, who had diabetes or other cardiovascular comorbidities, had a substantially lower 1-year risk of subsequent MI or death if they had follow-up after their ED encounter with a cardiologist compared to those who saw their primary care provider or had no follow-up. So the conclusion from these 2 studies is that cardiology follow-up after emergency discharge, emergency department discharge, saves lives. So a general theme in this population data is that patients who are referred for cardiology follow-up after an ED chest pain encounter may have better short-term and long-term outcomes. I think, though, that we need to consider the flip side of extrapolating too much from this data and think a little bit about our own referral practices and whether we might actually be referring more patients than we necessarily need to. And the first potential adverse effect of over-referring low-risk patients is simply cost. And so I'm going to engage in some really low-brow, rudimentary back-of-napkin calculations here that you can probably poke some holes in, but bear with me. So if you consider that Canadian emergency departments see about 650,000 patients a year with chest pain, and we discharge about 85% of those. Of those discharged patients, we saw from the Alberta and the Ontario data that we refer about a quarter of those patients for specialist follow-up. So about 140,000 patients a year. And consider that the cost of an outpatient consultation varies from province to province, but hovers around $200 a pop. And so just the cost of outpatient consultation alone is getting pretty close to $30 million a year. Now, that doesn't factor in the cost of downstream cardiac testing. And so if you consider conservatively, and what the folks at Total Cardiology tell me is that of the patients that we send them, they do objective testing like a treadmill test or a nuke on about a third of the patients that they see. So take those 140,000 patients that we refer to specialists every year. And if we do a stress test or other test on about a third of them, multiply that by about $80 a pop for a stress test. The cost of outpatient referrals after an ED chest pain discharge is easily north of $30 million a year across the country. And that's still not taking into account the costs that stem from false positive stress tests and patients who, who get committed to having other non-invasive imaging or cardiac caths after a false positive stress test. So the cost of chest pain follow-up is substantial. Some other pieces of evidence that we may be over-referring low-risk patients after discharge. These are some numbers that come to me from Todd Anderson, who used to be the director of the Libin Cardiovascular Institute. At least across the province of Alberta, the availability of chest pain follow-up clinics, or the absolute number of chest pain clinics, has quadrupled in the last 20 years. So in the year 2000, there were 7 chest pain clinics in Alberta. Now there are 28. And granted, the population has been growing in size, but it certainly hasn't been quadrupling. And so it leads to the question, is that demand for outpatient cardiology services partly as a result of over-referral of low-risk chest pain patients from the emergency department? And the consequence of that is that there probably is a subset of patients who really would benefit from outpatient cardiology follow-up. But when the system gets clogged with a bunch of low-risk patients, then the access for those patients who really need it gets limited. Some other things that we don't always consider too is what's the impact on the patient of sending them for cardiology follow-up if they really don't need it. So does it cause them additional anxiety or stress? Are there other factors related to needing to take time off work to go to cardiology appointments and that kind of thing if they don't need it? What's that actual impact on the patient? And we don't have a good handle on that at all because nobody's ever really asked the question. And there's also the issue of iatrogenic harms from false positive stress tests. So patients who have a false positive stress test necessarily are going to get shunted to having additional investigations, whether it's an MPI or a coronary CT or referral for cardiac cath. And so we don't have a good handle on what are the risks related to radiation exposure. Contrast nephropathy in cardiology, at least, is a real thing. It's not necessarily the way it is for a CT in the emergency department, but in the contrast doses they use in the cath lab, it's a real thing. And vascular injuries from vascular access. The risk is really, really small, but it's not zero. And we just don't have a good handle on what the magnitude and frequency of those risks are. Finally, I'm going to present some additional data from that Ontario group that I cited earlier. There's some evidence that the improved outcomes observed after specialist follow-up might be an example of what's colloquially what's called an ecological fallacy, which is a problem when you try to draw individual patient-level conclusions from population-level data. So looking at a population of higher risk patients, so almost 60,000 patients who were 50 years of older, who had diabetes or previous cardiovascular disease. 17% of those got cardiology follow-up in the 30 days after emergency department discharge. And they looked at the factors that predicted whether a patient got cardiology follow-up or not. And the factors that were most strongly associated with cardiology follow-up were if you were male between the ages of 50 and 69, if you had a cardiology in the emergency department or in the previous year, or if you were seen at a cardiac or tertiary teaching center. Some of the factors that were associated with not getting cardiology follow-up in the next 30 days were if you were older, or if you had a substantial burden of pre-existing cardiovascular comorbidities, or if you had dementia. Now, you might conclude that these sicker, higher risk patients weren't getting sent to a cardiologist because we already knew that they had bad disease and the risk might not necessarily be modifiable by additional specialist consultation. But one of the conclusions, an alternate conclusion that you might think about is, does this data suggest that some of the apparent advantage of sending patients to cardiology follow-up might be happening because the patients who are actually at the highest risk of an adverse event are the ones who aren't getting cardiology follow-up. So are we potentially referring the wrong patients for outpatient cardiology follow-up after an emergency department visit? Now, any claim that we're over-testing patients after discharge only holds water if the risk of an adverse event is really, really low. So we need to have the sense of what's the actual risk of an adverse event in patients who have reassuring high sensitivity troponin results. And we can use data from some of the studies that evaluated the rapid diagnostic algorithms to generate the clinical pathway that James just talked about. So let's start with a 2x2 table. The outcomes are on the top and the workup results are on the side. And so the risk of an adverse event, or the post-test probability of 30-day major adverse cardiac events, if you've been paying attention in ClinEpi class, is the risk of a false negative divided by all negatives. And so in this case, the risk of 30-day major adverse cardiac events after a 2-hour troponin algorithm is 3.7%. And James showed some tables earlier that the vast majority of those events were revascularizations. And so let's look just at the really, really bad outcomes, patients who had an MI or death in the 30 days after their 2-hour troponin workup. So again, same 2x2 table. Their post-test risk of 30-day death or MI after a 2-hour high sensitivity troponin algorithm is 1 out of 350, or 0.3%. And that's in the same ballpark as the 0.05 or the 0.1% death risk that was observed in the cohort of Alberta chest pain patients that I presented at the very top. So the bottom line is that the risk of a serious adverse event after a careful, thoughtful emergency department workup, including high sensitivity troponin testing, careful ECG evaluation, and a thorough history, is probably well below 2%. And the risk of a subsequent MI or death is vanishingly small. So I'm not trying to say that specialist follow-up isn't important or doesn't matter or isn't valuable. What I want people to think about is not so much how can we reduce the number of patients that we send to our specialist colleagues, but I want us to think about how do we better match our referral choices to the needs or the risk of the patient in front of us. So if the goal is to get the right patient, the right follow-up at the right time, then we need more accurate tools to estimate patients' risk after ruling out an MI with high sensitivity troponin. And that way, those with higher risk would be referred for further evaluation, whereas patients with a very low quantifiable risk, the harms of testing probably outweigh the benefit, and they probably don't need to be sent for outpatient testing at all. Structured risk assessment tools, or risk scores, are probably helpful in these situations because they generally perform better than clinical judgment alone in estimating patient risk. So this is a study published by some British researchers in academic emergency medicine earlier this year that people may have seen, looking at the performance of clinical judgment or clinical gestalt in identifying patients with acute coronary syndromes. And the good news is that when we say a patient, or when an emergency physician says a patient definitely do not have an acute coronary syndrome, they're usually right. So the classifying someone is definitely not an acute coronary syndrome was 98 to 100% sensitive, which is really good news. The trouble is we only classify about 4% of patients as definitely not an acute coronary syndrome. And most patients that this group of physicians evaluated fell in kind of the middle of the bell curve of risk of acute coronary syndrome. And in the vast majority of patients, we just weren't as accurate as we would like to be in estimating the risk of an acute coronary syndrome. So to really optimize post-rule-out decision-making, we probably need a structured risk assessment tool to better, more accurately estimate what a patient's risk is of a 30-day adverse event. So to optimize post-rule-out decision-making, we need to have some conversations around which risk score performs the best, which patients do we need to use a risk score in, and at what point in the patient trajectory should we be using it. I've had the good fortune over the past couple of years to be working with Connor O'Reilly, who's a master's student in community health sciences. He just finished defending his master's thesis on this very topic. He completed a systematic review of clinical risk scores using high sensitivity troponin, looking specifically at patients who had MI ruled out using high sensitivity troponins. The upshot is that the sensitivity of most risk scores is really, really good. They miss very few adverse events in low risk patients. The score that seems to perform the best is a heart score with a cutoff of less than or equal to 3 to define low risk. And it misses very, very few patients. And compared to all the other risk scores, it classifies the greatest number of patients as low risk. And so it's probably the best match of sensitivity and specificity. So I'm going to focus on the heart score going forward, but you can insert any other risk score that you wish, because the points that I'm going to be making are probably germane to all of them. And I'm going to take a critical eye on how these risk scores may or may not meet our needs for clinical decision making. The next question is, which patients should we use a risk score in? And if you look at our cognitive workflow, we would use a risk score in patients who have non-ischemic ECGs and reassuring troponin results to predict the risk of an adverse event after an emergency department discharge. The trouble is, this isn't the population that the heart score or any other risk score was developed in, nor is it the question that current risk scores were developed to answer. And so we can't actually hang our hats on the risk estimates that the heart score gives us if we're trying to apply it to patients after a 2-hour high sensitivity troponin algorithm. And I'm going to explain this in a lot more detail, because it's a challenging thing to try to pick apart. So if you look at the heart score validation paper, so Barbara Backus and Jacob Six from 2013, the inclusion criteria for their cohort was basically any patient who didn't go directly to the cath lab. It was all patients with chest pain, including those who were subsequently diagnosed with non-STEMIs or unstable angina in the emergency department. So it's not the population that we're concerned about, or the population that we're trying to make risk estimations in. So the population that the heart score was developed in, and most other risk scores for that matter, is undifferentiated chest pain patients. The outcome that they were interested in predicting was 42-day major adverse cardiac events. But what we don't often realize is that that 42-day outcome included non-STEMIs and diagnosis of unstable angina on day 0, or the day that they arrived at the emergency department. And so they used 42-day MACE as a surrogate outcome for identifying patients with acute coronary syndromes on the day of their index visit. They were trying to pick up patients who would have had non-STEMIs that were missed by conventional troponin assays, and they were trying to pick up patients who had unstable angina on the day of their index ED visit. So they used this surrogate outcome of 42-day MACE to try to identify patients who had an acute coronary syndrome on day 0. So it's not really a prognostic outcome. So just to illustrate this graphically, here's kind of a time continuum from day 0 to day 42. The outcome that they were looking at looked at outcomes basically from the time of emergency department arrival out to 42 days. So it's not really a prognostic outcome. If they were trying to make prognostic predictions, they'd be looking at outcomes from day 1 onward. And so by capturing all of the outcomes that happened on their initial emergency department encounter, they're really developing a score that serves best to identify outcomes that are happening on day 0, because that's really when most of them are happening. So the upshot is that the heart score is really a diagnostic tool for acute coronary syndromes on an index emergency department encounter on the day that you see the patient in front of you. It's not really a prognostic tool, but because they use the surrogate outcome of 42-day adverse events, it's gotten kind of co-opted or crept into being used as a prognostic tool, but we just don't have a good handle on how the heart score actually performs as a prognostic tool. No one's ever really looked at to see how the heart score performs in patients who've already had an MI ruled out using high sensitivity troponins. So I'm gonna illustrate this graphically another way, just to make sure that we're really clear on this. So what the heart score development studies did, they started out with an existing population of undifferentiated chest pain patients, and their goal was to identify patients who had acute coronary syndromes, including non-STEMIs, on the day of their ED presentation. And so it's really a diagnostic test for acute coronary syndromes. And then what they tried to do is identify a very low risk population who didn't have acute coronary syndromes on their index visit, but they didn't make any comment around what should we do with those patients once we've identified them. And so it's a diagnostic test. It's not a prognostic test. And to be quite honest, it just doesn't fit with the cognitive workflow that we use in the emergency department when we're evaluating chest pain patients. We don't treat acute coronary syndromes as a binary all or none diagnosis. And so this is what things, to my mind, this is how we really go about evaluating chest pain patients in the emergency department. We start with undifferentiated chest pain patients. And the very first thing that we do, I mean, just picture the last, think back to the last chest pain encounter that you had. The very first thing that you do, sometimes even before you see the patient, is you look at the ECG on the chart. And if there's high risk ischemic ECG changes, from a disposition perspective, you're done. These patients don't need a risk score. They need a cardiology consultation in the emergency department. Then we do troponin testing to identify patients who have non-STEMIs. And again, if they have high-risk troponin findings, they have a non-STEMI. They don't need a risk score. They need to have their MI treated. Then there's a decent proportion of patients who have a pretty clear non-coronary cause for their presentation. So they have pericarditis, they have pneumothoraces, they have PEs, they have pancreatitis. We know the differential diagnosis of chest pain, and we identify a clear alternative diagnosis in a large proportion of patients. And so what we're left with is a much smaller population at risk. And so the group of patients who might potentially benefit from a risk score is much, much smaller than the designers of the heart score or other chest pain risk scores might actually have us believe. And in this smaller population at risk, the risk of a serious adverse outcome is much, much smaller. And so we should, with a better performing risk score in the right population, be able to identify a much larger group of patients who are potentially eligible for emergency department discharge without further evaluation or without downstream testing or referral to our specialists, and a much smaller population of patients who remain undifferentiated, who might potentially benefit from downstream testing. So we might be tempted to say, well, why don't we just use the heart score or another risk score with high sensitivity troponins? Because if they're low risk with heart score, they're low risk. And so, that we should be able to hang their hat on that, because even if, if they're low risk for an acute coronary syndrome on their index ED visit, then they're just low risk. And why don't we just hang our hats on that? And that's true. But what I'm going to argue is that in patients who are ruled out for MI using high sensitivity troponins, risk scores like heart are going to systematically overestimate patients' risk. And so we're going to classify too many patients as moderate risk and potentially over-refer patients for downstream testing. So this is some more work from Connor's master's thesis using the data from James's chest pain study that he presented earlier. I'm going to show something called a calibration plot. This is a visual tool that tells us how well a risk score does in predicting patients' expected outcomes compared to their observed outcomes. And the bottom line is the closer the blue line is to that 45-degree line that you see there, the better a risk score does at predicting patient outcomes. This is the calibration plot for the heart score in undifferentiated chest pain patients, so the population for which it was really intended. And so it actually, it sticks to that 45-degree line of perfect calibration really quite well. But if you apply the heart score to patients who've had an MI ruled out using high sensitivity troponins, things kind of go off the rails here. And so the upshot of how the heart score performs in patients after high sensitivity troponin testing is that if they have a low risk heart score, yeah, they're very low risk. The very, very few downstream adverse events are going to be missed. But the downside of using it is that you're going to classify at least 40% of patients as moderate to high risk. And so, you'll be safe in using it to make discharge decisions and not referring low-risk patients for downstream testing or for follow-up. But you might be over-referring patients if you hang your hat on using a heart score to make decisions around who to refer for downstream testing. So it brings us to where I'm at as a researcher, and I think we've identified a problem that if we address it, we can better match patient disposition to the risk of a downstream adverse event. But I need some input on where to go from here. One option is to develop a totally new risk score in patients who are ruled out using high sensitivity troponins. And if we were here in person, I could probably see a few people covering their eyes or rolling their eyes. And I gotta admit, I'm kind of skeptical that what the world needs right now is another chest pain risk score. Maybe it's just enough to try to tweak some of the existing scores like heart or something else, using existing data to try to change some of the coefficients or the score values that might make existing scores perform better in patients who've had MI ruled out using high sensitivity troponin. Or do people think that the risk of a 30-day adverse event, especially the risk of death or subsequent MI, is so low after being ruled out using a high sensitivity troponin pathway that we should just say, you know what, patients who rule out using a 2-hour pathway, by and large, don't need any downstream testing at all? Should we just implement a referral pathway that says if you have really low high sensitivity troponin findings, you don't need downstream testing, and just studying the outcomes and cost effectiveness and safety of that particular pathway? So my question to the audience as a researcher is, given what I've just presented, what do you guys think will best meet your needs and your patients' needs? And I'd like to stop there, and now is probably the right time to try to address some of the questions that all of you have shared with us. All right. So, yeah, so James, it looks like you've answered some of the questions online in typed form. Just in case people don't have access to the Q&A, do we need to factor in duration of chest pain when making decisions around using the 2-hour pathway?
Yeah, so yeah, I'll field some of these then. Yeah, so do we have to factor in duration? The way we do factor in duration is only that you cannot use a single rule out for patients. So the low troponin on presentation, less than 5 nanograms per liter, you cannot use that if their symptoms have started less than 3 hours ago. However, you can absolutely use sorry, I'm actually jumping to Ian, I think it was Ian's question. So Sean's question, sorry, do we have to factor in duration of chest pain? Not specifically. The pathway did not distinguish between the duration of chest pain. And so if they rule out, the results are valid within the data that we've already presented. However, if someone has very clear exertional chest pain at the second that they start exercising or walking, they get significant chest pain or other suspected ischemic symptoms, to me, that's a high-risk clinical story, and that clinical history trumps biomarker results every time.
Yeah, and so a question around whether our cardiology colleagues, what's the degree of buy-in to this pathway, and concern around practice variation amongst cardiologists for patients who are in the observational zone with a good story, or who have small but potentially concerning troponin rises.
As I think we've all seen, it's highly variable. And I think that case that I presented in my talk is the perfect example of that. And I think part of our job will be to educate people. You know, once we have our paper is in press in the Canadian Journal of Emergency Medicine right now. And we'll have a real clear reference to share with people and quote rather than just some off-the-cuff data that we've shared here. But it is variable. A lot of cardiologists tend to minimize the patients with observational zone deltas in particular. But I think it's our job to advocate for the patients and to educate wherever possible. Variation exists both among cardiologists and among our own ED colleagues. One thing I will say, by the way, is anytime you see a troponin, if you see a troponin in the abnormal range, let's say 15 to 30, in someone that's 50 years old or less, and doesn't have an obvious reason for it, take that very seriously. Even recently, I've seen some patients that have had, patients in their 30s with troponins in the 20s and sent home based on a single troponin result. It doesn't necessarily mean it's ischemia, but think of other causes and just be very, if this is a new troponin, even if it's not a clearly rule in level, take it seriously and at least pursue it. Look at the medical record to see have there been similar results in that range. And if there haven't been, repeat it and try to understand why.
Some really good questions around troponin deltas and absolute values in patients with chronic kidney disease. I'm working on trying to get a paper published on this, but there's not a whole lot of literature around it. The bottom line is that if their kidney function is not bad, so if they have a GFR of 45 or higher, then the deltas will probably be quite similar, and the absolute values for ruling in or ruling out MI are going to be quite similar, but things really go off the rails, especially in patients who have GFRs of 30 or less. And so there's no hard and fast rules. Most of these patients are probably going to end up needing a 4-hour troponin to really get a sense of where they're get a sense of where their troponin is, what direction it's trending, and again, history is critical. Most of these patients have a substantially higher baseline cardiovascular risk, and so there's no hard and fast rules. And I think the take-home message, James, if you have anything to add, but my take-home message is approach with caution.
Yeah, I think approach with caution, and the absolute values are often going to be quite elevated. They may be elevated above our rule-in cutoff, and so be aware of that. A lot of patients have baseline troponins in the 50 to 90 range if you're end-stage renal disease on dialysis. But if it's rising, if there's a significant 2-hour delta, I'd pay attention to that. And if there's no alternative cause and the patient has what's a plausible chest pain history, I'd take it seriously.
Great. A couple more questions. So one around the high sensitivity troponin I pathway used in urgent cares and rural EDs, requiring a 0 and 2-hour value for all scenarios. And is there any research or data that would support a single value cutoff? So like a one and done for patients who've had greater than 3 hours from their onset of chest pain?
Yeah, so there are. I mean, there's for a number of the alternative assays, aside from the T assay that we use in the Calgary EDs, we certainly there are data that validate single rule outs with the other assays. The lab in Calgary has been reluctant to advocate for that until they had some local quality control data. And I know they were working on collecting those data over the past year. Obviously, the lab has had to rapidly change priorities, and I think everything went around, has all their resources had marshaled around COVID testing, so that's probably delayed. But almost there are data out there, and almost certainly we'll be able to advocate for that within the next year.
Great. And thanks to Katie for that comment. That I'd be very interested to see if established or used or easy to remember risk scores can better be better recalibrated for our population of interest. Thanks for that. I think that I would agree with that direction. I think people aren't gonna. I think it's gonna be hard to encourage people to use a completely new risk score compared to one that they've seen before. I've seen for the last 10 years. So yeah, I think that's probably the right way to go. And I hope that that a recalibrated heart score, for example, does the job that we need it to. We don't know yet. So, and then any relationship between the troponin I at urgent care clinics and our troponin, or do we have to start over numerically once they arrive at the ED? And why are there two different troponins being used in the region?
Okay, well, so I'll take that. Yeah, so that again, you have to start from square one. You can interpret the patient's results on these other pathways. Again, you could look at the Insight website to look at how to interpret the other pathways to see if they've already ruled in by a pathway. If they've already ruled in by one of these alternate troponin, high sensitivity troponin pathways, they've ruled in and you can consult cardiology right away, no problems. I would still recommend sending a new time zero troponin T when they arrive, because there is no way to convert between assays. They measure different molecules with both different release and clearance patterns, and there is no way to numerically convert between them. And I will also say we've seen a few cases of highly discrepant troponin I and troponin T results, where alternatively both the troponin T and the troponin I assay were at fault. And so if you see anything wildly discrepant, you think about the possibility that one assay may be erroneous.
Thanks.
Then there was a one from Kathy here that was also, I think, an important one. I answered it, I typed it, but when comparing a patient's current troponin level to that of a patient's troponin baseline, what would you consider a significant delta for these two values? My 2 cents are that, certainly if it's plus or minus within the less than 4 nanograms per liter that we are already using as a cutoff within our pathway, that's certainly well within the limit. However, if I look at Netcare and I've seen the past 10 visits that have been negative workups, not positive workups, where they got admitted and got a stent, showed troponin levels, let's say between 30 and 45, I would generally be comfortable with that being consistent with their baseline. But again, even in those patients, I'm looking at both a 0 and a 2-hour troponin level in most cases, unless it's an exceedingly low risk presentation.
And I think again, there's the question of what's their history, and is there a driving reason for them to have an elevated baseline troponin? Do they have documented chronic heart failure? Do they have documented chronic kidney disease? In which case we'd expect some, but not a great deal of variation in their troponin concentration at baseline.
And then there was a troponin timing question from Ian Walker saying, does this change for people with very early presentations, i.e. they arrive with pain that's been ongoing for only 30 minutes or so? The second troponin then would be 2.5 hours post-onset. Should we keep them for a third, or hold them until the time 0 troponin is 1 hour post-pain onset? And you don't have to. So again, once those people, again, you just cannot send those people home based on a single troponin result. But within the 2-hour pathway, you should already be seeing a rise in the troponin. And it may not have already crossed 14, but let's say they came in with a troponin of 5 and their repeat is now 9 or 11, certainly I'd be keeping them for a 4-hour troponin. But the pathway is absolutely valid. The 2-hour pathway is absolutely valid even for hyperacute presenters. Again, caveat being, a very high risk clinical story trumps biomarker results.
Yeah. And then just gonna maybe draw the Q&A period to a close with some good questions around maybe we should be looking more closely at patients who go down into at least start in the observational zone. And if they go into the observational zone after 2 hours, and then their 4-hour troponin is more reassuring, maybe these are the patients who might benefit from urgent outpatient referral. Instinctively, I think that's probably correct. I think the challenge is that the number of patients who go down into the observational zone is relatively small and so you would probably the sample size in our own local data is probably not large enough to be confident in the findings. And so one of the things I'm going to be working on is trying to get some data from other researchers in places like Australia, New Zealand, and the UK to try to pool our data and try to look at this exact question. So great question. Stay tuned, hopefully for something in the next 18 months or so. And then, yep. And then what about cardiology referring to demand ischemia and no need to admit these patients in the right setting? They just give themselves a stress test and need further workup or monitoring. I think that's going to be kind of a patient by patient decision. And I think we're getting into people's time. I do want to turn things over to Dr. Collins for a quick chat about COVID. We don't want to take up too much of his and the rest of everybody's time. So thanks everyone for all your questions and comments. Thanks for being here. It's a far greater turnout than we could have crammed into Coombs. So great to see everyone virtually. And then I think now is probably a good time to turn things over to Dr. Collins.
Hey, thanks a lot, Andrew and James. So if anybody ever questioned the utility of supporting researchers in our zone, I hope that those questions are put to rest with that very practical and expert presentation on a topic that is of enormous interest to us. It had the added benefit of not mentioning COVID more than I think once James did at the end. So I was certainly happy to not have to hear anything about COVID. So thank you both very much. That was an excellent presentation. I just have a couple of comments, you guys, and maybe I'll just, I just want to change hats from academics, and sorry if this is limited interest to those who are not emerge docs in the Calgary zone, but I just wanted to put in a plug for examining your line and giving some feedback to your scheduler and site chief about how many shifts you want for the fall schedule. So summer schedule is done. The next schedule to be made is fall. We have to make during the summer and late spring some hiring decisions, and we'd love to have some feedback from everybody. I know it may be difficult because of the alterations in our workflows and the number of shifts that are available because of this pandemic and difficulties with predicting what's going to happen in the fall. But if you can sort of sit back and think about what you'd like for a line, then give some feedback to your site chief and scheduler, and we'll put it on the Physician Resource Committee agenda, and we can change anything for the fall. Just a couple of operational things. Can I share my screen, please, Aaron? So you guys may have noticed that HS leadership changed the case definition for COVID. We're really being faced with decisions about how to work with new testing criteria. And, you know, really almost any symptom now can be used. I'm being a little bit facetious, but, you know, previously listed core ILI symptoms have now been joined by core GI symptoms, as well as expanded symptoms, including previously they were phrased as not feeling well, which really is going to be tough for us to use in the emergency department. So we're trying to work through an algorithm for testing, as well as separating patients into the isolation zones in our emergency department that are set aside for COVID possible patients. So this document is currently under production from IP&C, and it's not ready for prime time yet. I hope to be able to send it out in the next week or so, but what we use will probably be similar to this. So we'll be using core ILI symptoms as well as new vomiting and diarrhea greater than 3 episodes. And those things will be used to rule you in for the need for isolation and contact and droplet. If you don't have any of those, then you look at risk factors. So if you have close contact with a confirmed or probable case, and you can go through the risk factors, but travel, increasingly rare travel is listed in there. And you also need contact and droplet precautions. But if you don't have that, and you've got some of these other symptoms, it doesn't mean that you need contact droplet precautions necessarily. And you may not go into the isolation zone. So IPNC are happy with us just deciding to test those people with COVID-19, but not necessarily use full contact droplet in isolation. So if the patient's masked, we're masked, we have gloves on, we can go ahead and decide about testing those patients for COVID-19, but they don't necessarily have to be isolated. So, so that's probably how it's going to work out. I'll spend some more time with you all on this when it's finalized. The other quick operational policy that I want to discuss with you is our attempts to have be in compliance with AHS's recommendations that we use rapid for all transfers. So we initially didn't interpret this to mean in-zone transfers of patients, but it has been pointed out to us that we should be using rapid for in-zone transfers. We're working with Rapid and EMS to develop some protocols so that we can absolutely avoid transfer delays in people whose clinical presentation requires immediate transfer. So I'm thinking of sick trauma patients, acute strokes with major deficits, and of course STEMIs. So we're working on how we're going to use Rapid to facilitate transfer right now. But what I would say right now is that please have patient care as your primary concern and not adhering to any one protocol right now. And so if you have in your hospital a local protocol for getting the patient to, say, the foothills for a STEMI, using local EMS resources, unit clerk supervised protocols, then please go ahead with that while we work through these algorithms, and hopefully we'll have something up in the next couple of weeks. So that's all I have for the operational update, and I think that is it for rounds. And I'd be happy to answer any questions by email, but I think we'll let everybody go. So thanks again to James and Andrew for a fantastic set of rounds, and thanks for Aaron for facilitating all this through the Physician Learning Program. Thanks, everybody.